Welcome to the deep dive. Today we're getting into something called acquired arteriovenous fistulas, AVFs for short.
Right. These are basically unexpected connections, like little shortcuts that form between an artery and a vein, but importantly, they form after birth.
Okay, so not the kind you might be born with.
Exactly. Those are congenital, a different story. We're
Yeah.
focusing on the acquired ones. We'll look at, what causes them, how doctors spot them, and the ways they're managed.
And we're pulling this from pretty detailed medical text, yeah. The goal is to give you the important stuff, the interesting bits, without getting bogged down in like super technical jargon.
Definitely. And, it's interesting. This isn't a new discovery at all. Way back in 1761, William Hunter was already describing them.
1761, wow. What did he notice?
Well, he observed changes like the artery and vein near the connection getting bigger, dilating, and he felt this vibration, this palpable tremor.
Ah, the thrill you mentioned in the outline.
That's the one, yeah, the thrill. And also his sort of hissing or whooshing sound, the bruit, especially after botched attempts at bloodletting in the arm back then.
Right, phlebotomy. So for a long while, these were kind of rare.
They were, relatively speaking. But then the 19th century came along, and with it, warfare changed. You had high-speed projectiles.
Ah, okay. That must have led to different kinds of injuries, more complex ones.
Absolutely. High-velocity weapons just caused a huge spike in the frequency and complexity of vascular injuries. AVFs became much more common.
And that trend continued, didn't it? Even into civilian life.
It did. We started seeing more AVFs from, blunt trauma, penetrating wounds like stabbings or gunshots, and also importantly from medical procedures themselves.
Those are the iatrogenic ones, right? Injuries caused by treatment.
Exactly. Iatrogenic causes. So, yeah, today we're really focusing on these acquired AVFs, mainly caused by trauma.
But you mentioned some just happen spontaneously.
That's right. A smaller group can form spontaneously. This usually happens when a blood vessel wall is already weak. Think of an aneurysm, a bulge in an artery, or maybe a pseudoaneurysm.
Which is like a contained rupture.
Sort of, yeah. If that weakened spot, maybe due to atherosclerosis or an infection, erodes or bursts into a vein right next to it, you get a spontaneous AVF.
Okay, got it. So acquired is mostly trauma, some spontaneous. Congenital is off the table for today.
Correct.
Now, looking at the traumatic ones, the sources pointed out differences between military and civilian cases.
Oh, definitely. Big differences in both the cause and the location of the injury. In military settings, things like blasts, explosives, mortars, they account for something like 70% of vascular injuries.
50%, wow.
Gunshots make up the other 30% or so. But then you look at the civilian side.
And it flips.
Pretty much.
Yeah, okay.
Penetrating trauma is the main thing, gunshots and stab wounds. That accounts for over 60%, around 61.7% of civilian vascular injuries. It really shows how the environment shapes the trauma.
Makes total sense. And the location on the body. Similar patterns or different?
Well, arms and legs, the extremities are common sites in both groups. But there are differences. Lower extremity injuries seem more frequent in military personnel.
Any idea why?
The thinking is maybe body armor protects the torso, leaving the legs more exposed. It's a hypothesis.
Interesting. And for civilians?
Civilian gunshot wounds tend to hit the extremities too, but also the abdomen, pelvis, chest, neck. Stab wounds often affect arteries in the neck and upper chest. The common carotid artery is a frequent site there.
So it really paints a picture based on the type of violence or accident. You mentioned Vietnam War data. Did that add anything?
It did. A review showed a really high proportion of AVFs in the extremities, like over 85%. And specifically, the lower extremities were much more common than the upper.
So historical data confirming that pattern, at least for that conflict.
Exactly. It gives us a baseline to compare with, more recent data in civilian injuries.
Okay, let's shift gears to those iatrogenic causes, the ones from medical procedures. What kind of procedures are we talking about?
Yeah, these are a really significant group. Think about procedures where they go through the skin into blood vessels, percutaneous cardiac stuff, vascular interventions.
Like heart caths.
Right, heart catheterizations, also placing central lines, those big IVs. Orthopedic surgery, especially spine and knee operations, can sometimes cause them. Even biopsies, like kidney or liver biopsies.
So quite a range. Is there a specific spot that's more common for these iatrogenic injuries?
Yeah, down in the groin area, the right common femoral artery, that's the most frequent spot for these procedure-related AVFs in the lower body.
You'd think with more procedures being done, we'd see more AVFs. Is that the case?
Well, logically, yes.
Yeah.
But actually, the sources suggest it's a bit more complex. The use of smaller needles and especially ultrasound guidance during these procedures has really helped.
Ah, technology helping out.
It helps reduce complications at the access site, yeah,
Hmm.
but it's not perfect. There was a study comparing ultrasound guidance versus the older method, fluoroscopy, that's like live X-ray for getting into the femoral artery. And while ultrasound was, like, quicker for finding the artery,
The complication rates were similar.
pretty much, yeah. Similar rates of early and late complications, including AVFs. So technology helps, but careful technique is still absolutely key.
Right. Okay, let's circle back to the spontaneous ones. Less common, you said, usually from weakened vessels.
Correct. First described way back in 1831, actually. Often it's atherosclerosis, hardening of the arteries, or maybe inflammation, infection, weakening the wall.
And then it breaks through.
Exactly. It erodes or ruptures into the vein next door. The classic example is the aorta, the big artery, or the iliac arteries down in the pelvis, rupturing into the big veins there, the vena cava or iliac vein. Those are, major events.
I bet. Are there other conditions that make someone more prone to these?
Yeah, there are some rarer associations. People with certain connective tissue disorders, like Marfan syndrome or Ehlers-Danlos, their blood vessel walls can just be inherently weaker.
Okay, that makes sense.
And there are also really rare reports linking them to things like syphilitic aortitis or HIV arteritis, conditions that cause inflammation in the artery walls.
So a whole spectrum of potential underlying causes. Now, the text went into specific locations. Any examples that really stood out? Because they can happen pretty much anywhere, right?
They really can, and each spot has its own story. Take the innominate artery, a big one in the chest. Injuries there are rare in civilians, but they can happen, maybe from penetrating trauma or a central line.
And a fistula there, connecting to, say, the superior vena cava. That sounds serious.
It can be, yeah. Very close to the heart, major veins. That can have rapid effects. Then you've got the neck carotid artery injuries are more common.
From?
Penetrating trauma, again, stabs, bullets, but also catheter procedures, even blunt trauma sometimes. They usually connect to the internal jugular vein.
And the vertebral arteries. Also in the neck, feeding the brain.
Right. Those AVS can happen from penetrating trauma, but maybe more often from iatrogenic causes, neck surgery, internal jugular vein lines. Less commonly, blunt trauma, or even rarely, chiropractic manipulation have been implicated.
Wow. Chiropractic.
Very rare,
Yeah.
but reported. Spontaneous ones there are often linked to those connective tissue disorders we mentioned.
Okay. And then the limbs. Arms and legs. Common spots, you said.
Very common. The sources list them out. Axillary, subclavian, brachial, radial, ulnar in the arm, femoral, popliteal, tibial, peroneal in the leg. Each has typical injury patterns, like femoral AVFs in the thigh, gunshot stabs, maybe complications from hip surgery.
And popliteal. Behind the knee.
Yeah, similar causes often. The artery and vein are just very close together there,
Mm-hmm.
making them vulnerable during trauma.
It really is like mapping out the body's vascular weak points. What about inside the torso?
Yeah, you can get aortoilac AVFs involving those really big vessels. Those can be spontaneous, like we discussed, from aneurysm rupture or from trauma, or even rarely from things like lumbar disc surgery.
Oh, surgery. How's
Just the proximity. Instruments can inadvertently cause damage. Then there are renal ones, kidney AVFs, often after biopsies, and visceral ones.
affecting organs?
Right. Spleen, liver, mesenteric arteries supplying the intestines. Again, trauma, procedures, or aneurysm ruptures in those areas. The source even mentions rare uterine AVFs and ones developing after a DVT, a deep vein thrombosis.
That's a less obvious link.
It is. So yeah, almost anywhere, each with its own challenges.
Okay, so pulling it all together, we've got these acquired AVFs, mostly from trauma, some spontaneous, showing up all over the body. What's the big takeaway message here?
Well, the key is really that the size and the location of this abnormal connection, this fistula, are what dictate the consequences.
Right. It's not a one-size-fits-all effect.
Not at all. They can be totally asymptomatic, you wouldn't even know it's there, or they can cause really serious problems, heart failure because the heart's working too hard, or ischemia, where a limb isn't getting enough blood.
And identifying them. You mentioned the thrill and the bruit from Hunter's time. Are those still useful?
Oh yeah, definitely. Feeling for that vibration, listening for that whooshing sound with a stethoscope, those are still important clues in a physical exam. Basic, but useful.
But we have better tools now, obviously.
Absolutely. Modern imaging is crucial. Color flow duplex ultrasound is huge. It uses sound waves, shows blood flow in real time. Then you have CT angiography.
Using X-rays and contrast dye.
Exactly. Creates detailed 3D maps of the blood vessels. and MR angiography using magnets and radio waves. These tools let doctors see the fistula, see how blood is flowing, measure things, and really plan treatment.
Okay, so once it's diagnosed with imaging, what's the plan? How are they managed? Sounds like it varies.
It really does. It's very tailored. For some, especially small iatrogenic ones that aren't causing problems, the approach might just be watch and wait.
See if it closes on its own.
Yeah, sometimes they do. Maybe try some external compression. But for bigger ones, or ones causing symptoms, or ones that just aren't closing, you need active intervention.
And what does that look like?
Well, there's a whole range of endovascular options now, minimally invasive stuff. One common technique is embolization.
Blocking it off.
Right, using tiny coils or special glue delivered through catheters right to the spot to plug the connection. Or they can place stent grafts.
Like a covered stent.
Exactly. It's a tube covered in fabric, placed inside the vessel to kind of bridge over the fistula, creating a new path for the blood and sealing off the abnormal connection.
And if those don't work or aren't suitable,
Then you move to open surgical repair. That's the more traditional approach, making an incision, getting directly to the vessels, and repairing the connection surgically.
so the choice depends on the situation.
Totally. Depends on the patient's health, the fistula specifics, where it is, how big it is, what caused it, and, the available expertise. But the good news is outcomes for both endovascular and open surgery have gotten much better.
It's pretty amazing the toolkit they have now to fix these complex plumbing problems, so to speak.
It really is.
Yeah.
And, just thinking about how the body itself responds is fascinating. The vessels dilating, the flow changing,
Yeah.
how the body tries to compensate, and sometimes fails. It just shows how finely tuned that whole circulatory system is.
Yeah.
And like we said, this deep dive really just scratches the surface. There's so much more research, ongoing developments.
Yeah.
It's a really active field.
Definitely food for thought. And maybe for you, the listener, it sparks a thought about just how adaptable and sometimes vulnerable our internal systems are. It's a complex network in there. Thanks for joining us for this deep dive.